Good evening, this is Dr. Oak. Welcome to my channel, Critical Care Basics. As you all know, we are running ECG tutorials in this channel, and this is the 42nd ECG tutorial, I suppose. Then probably this is the last one on ECG, because after this tutorial we are going to focus on the other topics in critical care. So in the last lecture we discussed about the AV blocks. In the previous lecture to last one, we talked about the causes of AV blocks and type 1 first degree AV block. Then in the following lecture we discussed about the Venke black, that is Mobitz type 1 block. And in this lecture we are going to talk about Mobitz type 2 and complete heart blocks. So let's discuss Mobitz type 2 second degree heart block and complete heart block. This is a repetition slide. We have already seen the definitions of second degree heart block. In second degree heart block, some atrial impulses fail to reach the ventricle. So atrial impulses are represented by P wave in ECG. Sometimes the P wave does not get conducted to the ventricles. That is, there is no QRS that follows the P wave, and that is the diagnosis of second degree heart block. In Mobitz type 1, in successive beats, the PR interval gets prolonged and then the P wave fails to get conducted. While in Mobitz type 2, there is fixed PR interval, and without a prolongation of PR interval, the P fails to get conducted to the ventricles. In high degree AV block, more than 2 P waves, successive P waves, are not conducted to the ventricles. So that is called as high degree AV block. And lastly, complete AV block or third degree AV block, in which the P waves or the atrial activity is independent of the QRS complexes or the ventricular activity. So both are independent of each other. So that is complete heart block. So in this slide is an example of Mobitz type 2 second degree heart block. You can see the PR interval is fixed in all the beats that are going to the ventricles, and some of the beats, some of the atrial impulses or the P waves are not followed by the QRS complexes. So this is Mobitz type 2 second degree heart block. The importance of second degree heart block is it is almost always a problem of a conduction system that is below the level of the AV node. So naturally this becomes more dangerous than the Mobitz type 1 AV block. 20% of the time the problem is in the bundle of His, and 80% of the time it is infrahesian or below the bundle of His into the bundle branches. So whenever a bundle branch is involved, the patient will also have a widening of QRS complex and axis deviation. For example, if it is a right bundle branch block, the axis would be deviated to right, and if it is left bundle branch block, the axis would be deviated to left. So if these additional features are there that could accompany the second degree heart block, sometimes there could be biphasic or trifascicular block. Bifascicular means, for example, an RBBB is associated with left anterofascicular block. Let's see an example. So in this ECG, you can see the typical findings of RBBB, like R as R prime pattern, wide QRS, and widened QRS, prominent R wave in V1, R as R prime pattern in V1 to V3, and slurred S wave in V6. So this is typically right bundle branch block. At the same time, you can notice significant left axis deviation with a small Q and tall R waves in left sided leads 1 and AVL, and a small Q and deep S wave, a small R and deep S wave in the inferior leads, that is 2, 3 and AVFs. So this is left anterofascicular block. So this is right bundle branch block plus left anterofascicular block. That means this is bifascicular block. This is an example of trifascicular block. The patient has right bundle branch block, RSR prime pattern, and slurred S wave in V6, QRS widened. At the same time, patient has left anterofascicular block, tall R waves in 1 and AVL, and small R followed by deep S waves in inferior leads. So this is right bundle branch block plus left anterofascicular block, plus you can see that the PR interval is more than 5 small squares more than 200 milliseconds. As you all know, PR interval is measured from beginning of P to the beginning of Q. So this is more than 200 milliseconds. So that becomes a first degree heart block. So when we have right bundle branch block plus left anterior fascicular block plus first degree heart block, that is called as trifascicular block. So when the patient already has bifascicular and trifascicular block, in that setting, if the patient also develops second degree heart block, that becomes even more dangerous. As in contrast to first degree AV block and Mobitz type 1 second degree AV block, these patients with Mobitz type 2 AV block usually have some symptoms. The symptoms could be vary in their degree. There could be minor symptoms like fatigue or some dyspnea or some chest discomfort, or there could be more severe symptoms like presyncope, syncope, or even cardiac death. The ECG findings, as we have just discussed, the PR interval remains constant in all those waves, in all those impulses which are transmitted to the ventricles, and some of the atrial impulses, the P waves, are not followed by the QRS complex. In this example, the QRS is narrow. This is another example of Mobitz type 2 second degree AV block. The PR interval is again fixed in all those impulses that are transmitted to the ventricles, but some of the impulses, the P waves, are not followed by the QRS complex. So this is second degree wave block, but the QRS is wide. How to distinguish Mobitz type 2 from other AV blocks? To distinguish this from first degree wave block is easy, because in first degree all the P waves are followed by QRS complexes. The only problem is the PR interval is prolonged. So differentiation from first degree AV block is relatively easy. In Mobitz type 1, the PR successively gets prolonged before the P wave fails to conduct to the AV node, to the ventricles. So usually it is simple to differentiate between Mobitz type 1 and Mobitz type 2. Sometimes when there is 2:1 block, it could pose us difficulty. And patient with third degree AV block will have evidence of atrial waves and ventricular complexes which are totally independent of each other. We'll see an example that will help us to differentiate. This is an ECG with first degree AV block. All P waves are followed by QRS complexes. The only problem is the PR interval is prolonged more than 200 milliseconds. In Mobitz type 1, the PR interval successively gets prolonged till one P wave fails to get conducted to the ventricles. In Mobitz type 2, we have just seen this ECG. The PR interval in all those impulses that are that reach the ventricles, the PR interval is fixed, but few impulses are not transmitted at all. So that becomes Mobitz type 2 second degree AV block. And in third degree AV block, you see the atrial activity and ventricular activity totally independent. This is the atrial activity. This is a P wave. This P wave is buried here. Another P wave. Another P wave. This P wave is here. P wave here. So the P wave or atrial rate is about 100 per minute. While the ventricular rate, this is the ventricular rate, the QRS complex is about 35 to 40. So ventricles are beating at a much lesser pace. Atria are beating at a rate of around 100, and there is no connection or no dependency in between. They are totally independent of each other. So this is third degree AV block. Now atropine or vagal maneuvers could be of help to differentiate Mobitz type 1 from Mobitz type 2. Atropine is a vagolytic, so it increases the heart rate. So whenever there is an increase in heart rate, say due to exercise or atropine or atrial pacing, this will worsen Mobitz type 2 AV block. While if you give atropine, because it is vagolytic, it may slightly improve Mobitz type 1 AV block. So this is a differentiating point. Similarly, vagal maneuvers may slow the sinus rate and allow more time for excitability to recover in the below the bundle office. So if you do vagal maneuver like carotid massage or Valsalva maneuver, you may actually find some improvement in Mobitz type 2 AV block, while in Mobitz type 1 AV block, the block will usually worsen. So this is a differentiating point. EPS is of very limited value. Nobody does an EPS for second degree AV block. in 99% of cases. Only when there is concealed junctional ectopic, you may sometimes require EPS. In EPS, you can see this is the atrial activity, atrial depolarization. This is bundle of hairs, Hessian activity, followed by the ventricular depolarization. Here you see the atrial depolarization, Hessian depolarization, but absent ventricular depolarization. So this is Mobitz type 2 AV block. The diagnosis, as we have just said, is mainly on the surface ECG. In patient with 2:1 block, there could be some difficulty in differentiating between type 1, Mobitz type 1 and Mobitz type 2. In those cases, probably you can try atropine or carotid massage, vagal maneuvers, and that may be they may be helpful in differentiating. So you can see the older ECGs, they will also help, or in a very rare patient you could going for EPS. Now, if the patient has Mobitz type 2 AV block, how do we manage this patient? So first of all, like all the emergencies in ventricular rhythm abnormalities, first check whether the patient is stable or unstable. If the patient is stable, monitor with transcutaneous pads in situ. If the patient is unstable, look for whether the patient is in acute coronary syndrome, like if the is myocardial ischemia likely. If yes, then go ahead with temporary pacing and treat myocardial ischemia. If no, then you can probably treat with beta agonist. You can start with isoproterenol or dobutamine or dopamine or epinephrine infusion, and if that does not help, then you can go ahead with temporary pacing. So this is the basic treatment for stabilization, initial stabilization. Once the initial stabilization is done, then evaluate for reversible causes like ACS with ischemia of AV node or myocarditis. Typically line myocarditis, with time it improves. Hypothyroidism, hypokalemia or hyperkalemia, hypervagotemia, and medications that impair the AV conduction like digoxin, beta blockers, or non-dihydropyridine calcium channel blockers like diltiazem or verapamil. If you identify any cause, then treat the cause, observe. If the block resolves, then observation, PPM is not indicated. While if it persists, then permanent pacemaker is indicated. While if you don't find any reversible cause, then the patient requires permanent pacemaker. So that was about the Mobitz type 2 AV block. Let's go ahead for the third degree AV block or complete AV block. This slide is again a repetition because most of the symptoms are similar. Patient may have fatigue, dyspnea, chest pain, syncope, pre-syncope or sudden cardiac death. Clinical features of third degree AV block will have atrial activity in form of P waves, will have ventricular activity in form of QRS complexes, but they are independent of each other, right? So usually the atrial rate will be faster than the ventricular rate, and there will be no association between the atrial complexes and the ventricular complexes. As a general rule, more distal the level of the block, if like it is below the AV node or below the bundle of hairs, then the slower will be the escape rhythm or the ventricular rate. If it is if the junctional rhythm is there, then the rate will be around 40 to 60. If it is infrahessian rhythm, then the rate will be around 40 to 50 or even 40 per minute. What is an escape rhythm? Escape rhythms occur when a pacemaker other than the sinus node. Normally the fastest pacemaker is the sinus node, that is why the sinus node takes over. But if the sinus node, the impulse from the sinus node, that is atrial impulse, is not reaching the ventricle, the other pacemaker, every conducting tissue cell has a property of automaticity. We have already discussed this in our previous lectures. So the cells, the lower cells will take over. So when the pacemaker other than the sinus node, it has sufficient time to depolarize, attain threshold and produce depolarization, then it produces what is called as an escape rhythm. In third degree complete AV block, the escape rhythm that controls the ventricles can occur at any level below the conduction block, and the morphology will tell us approximately where the block is. For example, if it is just in the AV node or just below the AV node, within the AV node, the patient will have complete heart block, but the QRS complex will be narrow. You can see the P waves here. You can see the P waves here. So the atrial rate is again around 100 and the ventricular rate is much slower, around 35 to 40, but the ventricular complexes are narrow. So this is complete heart block, but because the rhythm is coming from just below the AV node, the QRS complexes are narrow. Similarly, if the block is at the level of bundle of hairs, again the QRS complexes will be narrow. But if it is infrahesian, below the level of the bundle of hairs, then in complete heart block, the QRS pattern or QRS complexes would be wide. So this gives us an idea as to where the block could be. Differential diagnosis, you can clearly tell complete heart block from what is called as AV dissociation, right? There is atrial activity, there is ventricular activity, but they are independent of each other. So this AV dissociation clinches the diagnosis of third degree AV block. Rarely atrial rate is exactly twice the rate of the ventricle, so in that case there could be a confusion with the second degree AV block, but whenever there is slight variation in the exact multiples, so that will tell that this is a third degree AV block or complete AV dissociation. What do we do in complete AV block? So first follow the ACLS bradycardia algorithm from the American Heart Association. Whenever the heart rate is less than 50 per minute, maintain patent airway, ABC, oxygen, cardiac monitor, IV access and a 12-lead ECG. If the patient has symptoms of decreased cerebral perfusion, if the patient has hypotension, that means features of hemodynamic instability in form of hypotension, altered mental status, signs of shock, ischemic discomfort, chest discomfort or acute heart failure, then immediately give atropine and follow it up with transcutaneous spacing or beta agonist infusion if required. If the patient does not have acute signs of hemodynamic instability, then you can observe with transcutaneous spacing pads in situ. Then get an ECG done. If ECG is showing AV dissociation or complete heart block, first see whether the patient is stable or unstable. If the patient is unstable, start with giving atropine. If after atropine the patient gets stabilized, then put transcutaneous pacing pads and follow the algorithm. If the patient remains unstable, then start transcutaneous pacing. If the patient gets stabilized, again find for the reversible causes. If the patient again remains unstable in spite of transcutaneous pacing, then you can start with dopamine if the patient has hypotension, or you can start with dobutamine if the patient has evidence of heart failure, or if BP and heart rate both are normal, there is no heart failure, then you can do transvenous pacing. So even in this class, if the patient does not get stabilized very early, then you can do transvenous pacing and stabilize the patient. When the patient is stabilized, then you have to evaluate for reversible causes like acute coronary syndrome or hyperkalemia, Lyme's disease, any medication or vagally mediated. If you find some reversible cause, then treat appropriately and observe. If the CHB improves, no further treatment is required. But if you do not find any reversible cause, or after treatment of reversible cause the CHB does not resolve, then the treatment is permanent pacemaker. Now, few words about atropine. Atropine is the first drug you give in ACLS bradycardia algorithm. Atropine should be promptly administered if intravenous access is available, but treatment of the atropine should not delay treatment with transcutaneous pacing or chronotropic agent. Why? Because usually in complete heart block, the problem is below the level of AV node and atropine is not going to work there. The initial dose of atropine is 1 milligram. You can repeat it 3 times, so maximum permissible dose is 3 milligrams. A favorable response to atropine also suggests that AV block is due to abnormal conduction in the AV node, because distal conduction system is not sensitive to vagal activity, right? So atropine this is important. Atropine is contraindicated in patient with closed angle glaucoma, pyloric stenosis, myasthenia gravis, urinary retention or bladder obstruction, and some other conditions. So if the patient is conscious and the patient is not in slow PA sort of situation, you have got time, just have a look at these contraindications before giving atropine. Now, once you have decided that the patient requires a permanent pacemaker, we have seen this slide in earlier AV blocks lectures also. Just a revision, if you desire AV synchrony, right, like if the patient is a 90-year-old guy and he is not, not very well off, so what you will do is you will not go in for AV synchrony. You will also not go for rate response. Rate response means if the patient works, does an activity, so the rate should have improved to help the patient improve the cardiac output. So if in old patient, if it is not required, then you can simply put a VVI or ventricular pacemaker. If you do not desire AV synchrony, but you want a rate response, the patient is say 60-year-old. So even if he is not affording a dual chamber pacemaker, but you can going for a rate responsive ventricular pacemaker. So this becomes the second option. These are the cheaper options. Ideally, every patient with a pacemaker should have going for AV synchrony, right? So in AV synchrony, do you desire atrial pacing, ideally you should pace the atria and the ventricle. So both get paced in sequence with a delay that is normal, so that the cardiac function is most near normal. So if there is desire for atrial pacing, then again you can go in for, if you want rate response, then you can go in for rate responsive dual chamber pacemaker. If you do not want rate response, then you can go in for simple dual chamber pacemaker. This is an option for a patient who is say 70-year-old guy and who opts for a dual chamber pacemaker. This is a good option. If you do not require atrial pacing, so you can go in for atrial sensing ventricular pacing. So this is again a cheaper option. If there is desire for rate response, then you can put a ventricular pacemaker, rate responsive ventricular pacemaker, or if there is no desire for ventricular response, you can go in for ventricular pacemaker. So this is in short the selection of pacemakers in complete heart block. This is my probably last lecture on ECG tutorial. In the next lecture we'll go in with other topics of critical care. So thanks a lot. If you are liking these videos, do like, subscribe and share. Goodbye.